Ms. Sewell?
Thank you, Mr. Chairman. I want to thank all of our witnesses here today. Lowering the disproportionate rate of chronic diseases in my district in Alabama has long been one of my top priorities. As a representative of the historic Civil Rights District that includes the towns of Birmingham and Montgomery, my hometown of Selma, I am sensitive to the necessity to increase health equity and lower the rates of chronic diseases for most of America's most vulnerable population. Today's hearing presents an opportunity to discuss the need for a comprehensive approach to health policy that addresses the social determinants of health. I heard that from a lot of our witnesses today. It is no secret that on this committee, that citizens in states like mine experience some of the poorest health outcomes of any state in the country. In Alabama, 67% of the people are living with a chronic disease. That means 7 out of 10 people in my district and in my state have at least one chronic disease diagnosis. Without creating and supporting policies that would address the structural, socioeconomic, and environmental factors that lead to poor health outcomes, we will continue to experience high rates of chronic diseases. This is why I am a champion of the John Lewis Equity in Medicare and Medicaid treatment bill alongside my colleague, Senator Cory Booker. Under the current law, CMMI is not required to consider social determinants of health, such as the patient's environment, transportation or lack thereof, education, socioeconomic status when implementing and testing new payment models. This seems to me to be absurd. This lack of consideration for social determinants of health incentivizes health providers to pick patients who will produce favorable clinical outcomes. This oversight leaves women, rural citizens, Black and brown people on the sidelines when it comes to developing a payment model, and that's just not fair, nor is it equitable. I would like to invite my colleagues who have not signed on to H.R. 3069 to ensure experts at the Federal Office of Rural Health Policy and other agencies to weigh in on new payment models in Medicare that focus on social determinants of health. Dr. Peters, can you speak to how important addressing the social determinants of health is for improving healthcare outcomes in underserved communities like the urban and rural communities that I represent in Alabama?
I appreciate what you're doing, and I can tell you that social determinants of health are something that haunt me to some degree all the time because I'm so aware of the lives of my patients and how difficult they are. And so often the best doctor for their diabetes is a social worker because the social worker can help them deal with how to find food or how to get transportation. And then we specifically have been very successful, and we have done programs in our area like the GPP as well as Look Ahead, which was a study of weight loss and the treatment of type 2 diabetes, because my team, my educators come from the community. They work with the community. We have focus groups. We give the community the kind of care
and support that it needs
yes,
to
that
make
they need.
changes.
And then we have peer groups. And so I'm really sensitive to the need for communities to engage in trying to help us help them. But if you give them resources, and then of course you've got to give them access to the kinds of medications they need to help them.
And the access to the kinds of nutritional food that we want them to eat. I mean, it's sort of an odd thing to say that you have a choice if you don't live within walking distance or even driving distance to a supermarket that has fresh fruits. It's a false narrative to think that somehow that they're not going to get the sugary canned fruit if they, try to eat
That's how
healthy.
we succeeded in Look Ahead, was we gave them meal replacements. And we were as successful as at sites at Stanford and Yale and wherever else because we actually gave them food. And we gave them, at that point it wasn't such great food, but nonetheless you can do it. And I really wanted to make it something that the county would pay for is food.
No, I hear you. Listen, I feel very fortunate in my district. We have amazing partners like the Live Health Smart program sponsored by the University of Alabama, Birmingham, that has committed to providing or addressing social determinants of health. If that means a mobile unit that goes around and provides meal replacements or the like. But the Live Health Smart program is an example of the type of work this committee should be supporting. The program is committed to removing barriers in education and good nutrition, physical activity, as well as prevention and wellness. My constituents have benefited from the mobile food market that has provided access to healthy food options in 25 of the communities that I represent. In addition to providing access to healthy food, the program also revitalizes communities and neighborhoods by building parks and walking paths to encourage physical activity. I say this to say that we have to focus on social determinants of health and really tackle them if we really are to address chronic diseases. That may mean that we have to spend some money on the front end on prevention, but then we make it up, I would assume, on the back end by having less folks with chronic diseases and long-term death. So I hope that our committee, Mr. Chairman, will take this hearing and really make it, broaden it to social determinants of health and how our committee can address that. Thank you, sir.
You and I can work together.